today I'm very excited to share with you my knowledge. I mean, I have to say I have limited knowledge in this area, okay? As a biostatistician, I normally just go ahead and do it to design the study. I mean, since Paul gave me this assignment, I spent quite a bit of effort trying to, get into this field, to get a kind of global view about the pragmatic trial. So I think now I wanted to share, the understanding of and the knowledge I had with you, and also, and hopefully in the future, can help you out to design relevant pragmatic trial. Okay. First, this is my general outline. First of all, I would like, because everybody heard about ICT, right? Randomized control trial, or sometimes people call it randomized clinical trial. So it's kind of buzzword in conducting scientific research. So sometimes it's a great confusing in scientific research, whether it's a medical research or public health research or community engaged based research. So how you really distinguish, the explanatory randomized clinical trial versus pragmatic trial. So nowadays, people, the pragmatic trial become a very popular term people like to use. So I would like to take this opportunity, try to, elaborate the differences and the commonality between these two types of trial, and also give you a little bit about, the statistical consideration. Also, I'm going to talk about the tool to somehow help you to kind of examine the trial you design, whether it fits to the paradigm of, pragmatic trial, stuff like that, or what you really want to do, whether it's going to be the exploratory trial. Let me just go brief, like ERCT or PRCT. Then if you set up, the study design, either way, what would be in the statistical consideration for PRCT? I have to tell you, for the ERCT, generally speaking, the statistical parts is extremely easy, all right? So, just the intro stats probably suffice to conduct analysis if the trial is very well designed. But the PRCT, I have to warn you, the statistical portion is very complicated. Okay, there's a lot of parameters you need to take into account. Okay, so these require some kind of innovation in terms of the methodology. So I have done something in that area, so I can share something with you. Anyway, so in the end, I may engage you to do some exercise to learn, how to define the PICT with some concrete example. Okay. Then in the very end, I'm going to talk about the case study. So particularly relevant to this topic is community setting, community engaged, research. So what would be the challenge if you're conducting a PICT? So I'm going to give a failure example. So they didn't succeed, and even have a very nice, design for proof of concept or try to implement in the community setting, but unfortunately it didn't go through. So they summarized the lesson they learned from this setting. So I kind of pick up the paper to try to share with you. In the end, I'm going to talk about, it's a very typical design for PICT, which is a cluster randomization. So I'm going to share with you two of the research proposal I was involved. Basically, is the R1 application. So the typical setting of like a community engaged research. So using the cluster randomization. So then I conclude today's talk. Any questions so far? All right. What was ERCT? So randomized clinical trial was originally, it's basically focused on the drug development or investigate initiate research. So generally, when we talk about the randomized clinical trial, it's meant for the phase 3 clinical trial. So the phase 1 is mostly just clinical trial. The phase 1 is mostly an animal trial for the basically to demonstrate the safety of the intervention or the treatment, mainly when we talk about the drug. Okay, so the drug is, I mean, if you want to, before you want to use it, you want to demonstrate the first place whether it's safe, right, on the animal to start with. Then the phase 2 normally is try to demonstrate a certain amount of, efficacy in terms of to have a positive outcome by the intervention. So obviously this is all very scale. So it doesn't a very small scale. So even for the efficacy, so it's not like a deterministic efficacy. Basically, the phase 2 share some light. The intervention under the study may show some promising, okay, in treating patient stuff like that. Then if that gets demonstrated, then we're going to conduct a full-blown, so-called, powered randomized, phase 3 randomized trial. Okay, generally now in that area, in that phase, then we're going to have a very rigid, the statistical proof trial design. So, this contains a lot of components in there. So, generally speaking, when you conduct an ERCT for the phase 3 trial, first, we all know you're going to include the inclusion criteria, exclusion criteria. Basically, is try to make sure the patient population is very homogeneous. Okay, it's very homogeneous. Now you can actually using clinical trial to detect the average effect size, whether it's clinically significant to promoting this intervention or treatment or not, something like this. Okay, so see, again, it sounds like it's not very pragmatic already, right? Patient population gotta be homogeneous, very homogeneous. Okay, so the next issue is talking about the bias, whether the inference you derive is biased or not. So in order to prevent the biased inference, early on, so this is related to some kind of early stage of a randomized clinical trial I think it's back into 40s, 50s, but the early time, people wouldn't even think about the randomization. Why randomize? If you think the drug is useful, the clinician just say, let's just do it, right? Otherwise, if you don't believe it's useful, why you do it? If you believe, the physician believe this is good for people, just do it. Why are you using the placebo or stuff like that, right? If you already, for some smaller scale study showing some efficacy stuff, why bother to have a placebo or whatever? So anyway, so until, I think it's in 52 or what, Paul Meyer, who is a very famous statistician and epidemiologist, and actually using a very fine mathematical argument to demonstrate, if you don't do randomized trial, okay, the randomization, the inference you derive is biased, okay? It's biased. It doesn't really tell the efficacy of the intervention, okay? So, this is I think it's a revolutionary finding. It's a very simple mathematics, but it's a revolutionary finding. So when I teach statistics, this is something I must present to the students. I think it's so important. Since then, kind of randomized trial become a standard to demonstrate, drug efficacy. And why it's blind? So sometimes even, when we really put in the a standard study protocol, people also require blindness. So investigators need to be blinded. participants, I mean, double blind means, I mean, investigator need to be blinded, and also, I mean, the patient need to be blinded. I mean, definitely, I mean, this is necessary. So the reason for doing that is try to avoid subjective outcome. You know, I mean, a lot of time, I mean, the outcome or the study endpoint you're choosing is not every trial is objective. Okay, sometimes it's subjective. I mean, sometimes the patient, if you're telling them, are you being untreated, on the treatment, stuff like that, they may credit to any improvement to the treatment, right? For the psychological issue. That's actually the placebo effect, all right, need to be kicking out. So that's, and also, you know, obviously we believe everybody conduct the study has an academic, you know, integrity. But as we all know, I mean, it's very difficult to publish a negative outcome, right? Research. So sometimes investigators tend to lean, you know, exaggerate the positive outcome, you know, for the treatment. So that's to avoid that thing to happen. So very important. Sometimes we need to also blind the treatment assignment to the investigator as well. So that's called a double blindness. But not every procedure or treatment can be done, you know, blind, you know, can be blinded. Right? Like if you have a surgery or stuff like that, you certainly cannot blind, right? Only the pill, maybe you can with the placebo. All right, that's the statistical consideration. So then that often when you conduct ERCT, particularly for the drug trial, I always start with the drug trial. Okay? So it's often it's a multi-site clinical study. So I mean, each site you choose have probably many years experience in conduct clinical trial. Then in conduct this type of clinical trial, you need to have a centralized study protocol. So it's a unified, you know, participant recruitment plan for each site. Then you definitely need to develop the informed consent one, right? To ask patient to sign. Then you have a very rigid clinical visit, you know, to plan out, to collecting data. And also most important is the aim, you know, hypothesis. What do you want to do? So this hypothesis, you need to make sure it can be tested. Okay, the scientific hypothesis can be tested by the data, which means can be done in, I mean, statistically. So, and another very important thing, component is the study endpoint. And this is very crucial. Okay, I mean, study endpoint somehow can help, can assist to determine whether this trial is going to be pragmatic or totally just, you know, ERCT. And also the data collection, how you're going to collect the data, that's actually also distinguish the pragmatic trial PRCT and the ERCT. Often when we do the drug trial, see, we want to make sure, I mean, the data we collect is very accurate. So often we need to develop case report form, ECRF, okay? And also we need to double confirm. Oftentimes when you enter the data from the paper version to the computer version, we need a second eye to check the validity, okay? To validate the data entry. So whole business is try to make sure the data we enter has a minimal error, okay? And also we need developing some kind of protocol deviation, the plan how to deal with the protocol deviation, okay? Then in the end, you have to develop a very comprehensive SAP. So make sure, you know, you make some kind of statistical template, statistical analysis template. So what you're supposed to do in stage 1, you know, recruitment, how the recruitment go, how the process go, and also very important, you know, determine the sample size and power. So then you kind of develop the interim analysis plan. Sometimes for the drug trial, it's very important. I mean, the drug company, people always have this kind of interim analysis plan to build in, mainly sometimes check only efficacy. Sometimes they also check the efficacy and the futility. So also this is for saving the resources, and also on the other hand, it's basically try to make sure that, I mean, to ensure the ethics, right? If the drug has been already proved efficient, we just go ahead, to implement it. So if it's, I mean, kind of showing it's impossible to establish the desired efficacy, maybe we should stop early to save resources for other trial. Actually, in big drug companies, so a lot of time you have a lot of drug candidate, but very few can get to the official trial. Mainly just to developing, to discover a new treatment, a new drug, is very, very expensive. Okay, so I mean that's why, I mean, the drug trial definitely you need to have this in there. So you have developed DSMB, to check the efficacy and the futility for the interim, and also very important to monitoring the safety. Okay, so again, for the safety consideration or the ethical consideration. So I mean, a lot of times, sometimes I feel people thinking about, I mean, the statistical consideration always just saying, oh, sample size and the power. Just seems like we just plug in the formula to calculate the sample size and the power. That's actually not. As a statistician, I mean, I always advise people, if you want to conduct a very rigorous trial, you better to involve the statistician as early as possible. So, I mean, it's not just about plugging the number to get plugging into the formula to get the number. A lot of very depth consideration, in-depth consideration need to be taken into account in the early on. Okay, because conducting a clinical trial RCT, it's a very expensive. Okay, I mean, can be very tedious, very frustrating. Also, I have to say. Okay. All right. So clearly, the FDA and also NIH develops the called a good clinical practice guideline. So to conduct clinical trial. So generally speaking, for the eRCT, I mean, normally this RCT conduct in the artificial environment, which means this deal with the scenario as the ideal scenario. I mean, give a simple example, just homogeneous sample, homogeneous population, that's really the ideal scenario, right? So the purpose for this eRCT is, I would say for sure, is proof of concept. So in other words, to put it, is basically this trial is focusing on maximize internal validity. Okay, internal validity, just try to, mainly just, as I said, prove the concept, mainly just prove prevent the biased inference from the data, all right? So, this automatically imply, the results you're getting from this ideal scenario does not necessarily immediately apply to the real world scenario. Okay, the real world scenario, if you see the efficacy, if you see something treatment efficacy, that means if the real world scenario is basically impact people's day-to-day life. All right, so that comes to, the limitation of RCT. So immediately it's just, this is mostly for scientific purposes, right? For proof of concept thing. Oh, this discovery, some new aging, new treatment has a potential, to helping people, right? Whether it's truly be able to help people or really can be implemented into day-to-day and usual care, that's, another issue, okay? So regardless I mean, whether you can directly apply the outcome in the ERCT to the day-to-day life. I mean, conducting ERCT in general, it's not easy. So, well, there's a lot of people give a summary review about the ERCT. Mainly just, I mean, the shortcoming of the ERCT is slow, generally speaking. All right. So the systematic review showing, 50% of trials fail to recruit the target. Even you design, I'm going to recruit like 300 people, 400 people based on statistical consideration, but 50% of trials fail to recruit the target. There's a lot of issues like patient recruitment need to be taken into account. Okay, very, in the early on, you need to consider that very carefully. Even if you're able to do so, and the 50% of that will exceed their planned recruitment period. That's part of the reason that we need to have a DSMB meeting. Every time when you have this meeting, you need to check that recruitment, whether it's on the target or not, whether, you have a chance to complete, the trial in a reasonable time frame. That's very important. And needless to say, it's very, very expensive. So the median cost, about 726 pharmaceutical intervention trial, we summarized in 2017, is cost like more than $21 million. All right. So another issue, the shortcoming of ERCT is the funding, usually lack of real-world evidence for treatment efficacy. So you have a scientific evidence, but it's not necessary. Scientific evidence find, the mechanism basically happen in the ideal scenario does not necessarily imply the real evidence that can be immediately reflected in the usual care. So that's the issue. Okay. So now, having said about RCT, now let's talk about PRCT. So the PRCT aim to provide information to pragmatic trial on the relative merit of the real-world clinical alternative, in routine care. So see, the keywords in the usual care or sometimes in routine care. All right. So which means the finding from this randomized trial can be immediately, reflected in the general practice, so people can benefit immediately from that. So the focus for PRCT, as you can see, it's maximizing the external validity. Okay, so which means is a more focus on generalizability to the usual setting, rather than focusing on internal validity, which try to prove the concept. Okay. So, but at the same time, also try, the trial try to preserve as much as internal validity as possible. Okay. So sometimes for instance, if the proof the concept demonstrate the new treatment or new intervention in the real scenario, in the ideal scenario, let's say 1.5, okay, treatment effect size. You can, in the practice, you can achieve 1 standardized effect size already pretty good. Okay, so you still try to preserving the internal validity in some degree. So that's the PRCT. So now, relative to ERCT, what's the core characteristics of PRCT? Right. So the question is not necessarily has to be very innovative scientific question. Okay. So as you can see, it's a lot of time the research question is directly or important to stakeholder. Somebody care about this study, right? Doesn't have to be scientific, innovative, okay? It's for practice, okay? And also, because you want to apply to the usual care, so, I mean, the results supposed to be applied, you know, to the diverse populations, okay? Which means, I mean, it's applied to the heterogeneous setting, it's not homogeneous setting. Okay? Then often, when not, because it's not mainly for proof of concept, you may look at different multiple outcome, all right? So it's not just single one thing out, prove this is true. So you want to look at it when you have the new treatment or new intervention. You know, what it will do good, you know, in general, okay? In what aspects? So that means you may look at multiple outcomes. And also, I mean, generally for the PRCT, the comparison is not between a single outcome, a single treatment versus placebo. Okay? Normally, it's compared with alternative. You have a multiple intervention, multiple treatment. You want to demonstrate the new treatment you developed is better than the other. I mean, from different aspects. Maybe it's easy to implement. It can be accessed by more people or things like that, right? So, and also maybe it's cheaper, so, but still has a acceptable, you know, effect, something like that. So nowadays, comparative effective research CER is pretty much, you know, last couple of years is basically I would say it's pretty hard. It's a buzzword in many new area of research, right? PCORI, NIH kind of try to promote those type of research as well. So basically, for demonstrate the efficacy in the comparative effective research, then generally, if you're thinking about randomized clinical trial, generally that's going to be the pragmatic trial, okay? All right. So now let me briefly give you some difference between ERCT and PRCT. So there's a number of questions, you know, before you thinking about, you know, or participating in any trial or design a trial, you have to ask several questions. For pragmatic trial RCT, you know, it's pretty straightforward. So it's important to us, absolutely. I mean, this is immediately applied to our daily life, right? For the ERCT, well, yeah, scientifically maybe very important, has a great potential, but immediately important to us or not, don't know. Okay, so can we do this here? As for pragmatic purposes, that's very important. So, I mean, the study need to be built around your normal healthcare, usual care operation. So, just thinking about in the general clinics, the research setting, I mean, the care setting. I mean, this can be done or not, or you need a special equipment, or you need a you know, a very refined environment to conduct this study or not. So that's the differences there. So would it be flexible to do it? So, or you have a very rigid protocol to do it. That's the question for ERCT. For the PRCT, you know, you must develop in some kind of flexible study protocol to allow the heterogeneous stuff, the setting, the heterogeneous in setting, population, all this kind of thing. So basically, you try to minimize the intrusion in your daily workflow. So that's very important, and will help our patient. Of course, I mean, in the PRCT, that's actually the goal. Okay, so you want to demonstrate, you know, explicit goal, which is the real-world evidence that definitely. Once it's demonstrated, it can immediately improve patients' care and the clinical decision-making. So but will they help patient? I mean, for any research, definitely that's the ultimate goal, okay? But for the ERCT, that may be not necessarily immediate goal for, helping patient. I mean, as I said, a lot of time it's a proof concept, right? Even as you can see, the pharmaceutical companies you're developing the trial they do is definitely ERCT. Well, after you've done this trial, will be immediately apply to treat patient. Well, again, it needed to be approved by FDA, right? It maybe take a lot longer to get through to the market.
Hey, Ying, I'm just going to pause for a second. I noticed that we had a couple of hands up. I think LeDan had her hand up, and I think Kate had her hand up. So,
oh, why did I see?
LeDan, why don't you go first, and then we'll let Kate go.
Sure, thank you. My question is about diversity, and I was wondering if I understood correctly that we do not necessarily need to stratify for different diverse groups, as long as we include enough number of diverse people in the population, and as long as we are just showing an effectiveness of our intervention over standard, for example, of care or something like that. Did I understand that correctly or not? Or
I think this is a very relevant question. Generally speaking, if you want to, this to be more applicable to the usual care, definitely you want to including, diverse study population, right? Whether you're gonna stratify, according to the, diverse population or something else, that's a technical issue. It's a specific to individual design, okay, individual study design. Could I answer your question?
Yes, would in any circumstance, would it be acceptable if we did not have, like, let's say my population is Nebraska, okay, and it's very hard to include diversity, especially Black people, for example, or Asian people in my population. Mm-hmm. So if I went by kind of the ratio of the population in Nebraska, like the number of Asian people would be really low in my sample. In a normal state, well, not normal state, but then in a typical state, for example, NIH would not accept only 2 Asians in my sample size, for example, or 1% Asian in my sample size. So, but given that this would be a kind of a pragmatic study if I'm doing it in Nebraska, I guess my question is, would I still have to go out of my way to find ways to recruit more Asian people in my population? Or would it be okay to justify that, well, this is a pragmatic study, this is the population I get?
Well, pragmatic study is not just for that diverse scenario, right? The setting. So really depends on what the ultimate goal you want to achieve, right? You want your study outcome applied to diverse the population, then you have to have, enough sample size from each diverse population. So now, clearly that's certainly a limitation if you conduct this kind of trial in Nebraska. So now you have to think about, if you really want to demonstrate that, you may want to, to developing a multi-site trial. For example, thinking about enroll patients from California, involve sites from California, okay, from, having a variety, diverse background. Really depends on the goal, what kind of goal you want to achieve. If you do this in Nebraska, generally, the outcome, you can only apply to mostly Caucasian population, right?
Okay. Thank you.
And Kate.
I'm really, I assumed is always a mistake. I guess I'd be curious to know how pragmatic RCT, that looks a lot like what I would call an implementation. I mean, we've got established science. It looks like we're trying to make it work in the real world. So we're informing whether this is how we implement this in a real world environment. I thought all randomized controlled trials were experimental in the sense of looking for cause and effect of treatment, causality. So this is a new concept for me.
Well,
and so are you going to show how a PRCT compares to implementation?
What is that again?
Are you going to show us how a pragmatic RCT might line up against an implementation science study?
No.
Okay.
That's not the So yeah, you're right. I mean, regardless, this is an experiment, right? This is experiment, either exploratory RCT or pragmatic RCT. The goal is try to derive the causal inference. Okay, so the causality is the goal, we want to achieve, but whether or not it's easy or hard, it's really depends on, the situation, each individual cases.
Okay.
I'm not saying this is against implementation. No, it's not. The PRCT, in order to implement the PRCT, there's a lot of fine, implementation science need to be taken into account. How you really implement that treatment.
Okay. Yeah. Well, normally in an implementation, you don't do randomization, you don't control. I understand all those differences, but I'm just really, I'm struggling with this new, the problem with having studied research 30 years ago is it's different now. So
I'm not saying anything here against implementations. Okay, it's not. I'm just talking about if you often you may need to end up with doing some kind of RCT because this is so popular. So people are thinking about the old investigator I deal with, work with in the past, first thing is thinking about, can we do this randomized trial? Something like that. So if you indeed cannot do that, then obviously how are we going to implement this treatment? Yeah. Right? Anyway, so this is not my focus.
Okay. Sorry.
Okay. All right. So now let's talk about precise to anybody heard about this term? Precise. So, again, let me clarify. I want to focus on RCT, okay? RCT, randomized clinical study trial, okay? So there's a two type. I kind of elaborated two extremes. One is ERCT, one is PRCT, but it's a continuing process, all right? The whole study RCT is not just easily you can call, oh, this is absolutely ERCT or this is absolutely PRCT. Sometimes it's somewhere between, okay? So, nowadays people would love to label and RCT as a pragmatic. That's kind of the badge of honor in some way. So people did some survey from the 1977 to 40 years. They kind of summarize these 15 trials were labeled pragmatic. So that's way ahead of the definition of pragmatic trials. People already use that term pragmatic trial because it's so kind of fancy, can attract people's attention. It's really useful, immediately applicable. So it's like that. So among this 615 trial, obviously a lot of them maybe indeed just the pragmatic trial. But if you're talking about something related to the medicine, they find out 89 out of 615, is a medicine. So among this, as you can see, 36% should not be termed as pragmatic. Okay, so some some trial basically is investigational medicine even prior to the licensing, so cannot be immediately applied to the usual care, right? It's still like a proof of concept things. So in investigational, investigated initially research all the time. I mean, 16 of this is a single center, then 4 is using the multiple placebo, then 14 use single placebo. So this is a placebo involved, definitely is not, generally speaking, is a pragmatic. Okay, in the real life, people don't use placebo, right? Okay. So in the end, I'm just saying, RCT should be considered as continuing. So somewhere, generally speaking, the RCT is the whole spectrum. In the left end, the far left is ERCT, far right is a complete pragmatic. Okay, so it's a two extreme in the continuum. So PRESIS stands for Pragmatic Exploratory Continuing Indicator Summary. Okay, I was originally developed in 2005 to 2008. People see the needs, try to clarify the differences and the focuses of the RCT. So people come together, those people mostly from Europe, England. Okay. 25 international trialists and the methodologists come kind of developing some protocol for the RCT things. So they want to look at a 10 domain to look at it, to define, this continuum indicator summary. Since 2009, 5 years, it's been cited this thing 3,300 times. But people find still a lot of confusing there. So, how to use this process, because there's no rating scale. And sometimes confused come from the overlapping of domains they put forward, and no better guidance on how to use this process. Mainly just, you want to understand whether the trial is extremely pragmatic or exploratory. And also the stuff they define is not really truly validated. So it's a updated version. That's the stuff people are using now. It's called a PRESIS 2, so version 2. So it's developed in 2015 with the evidence, with the information gathered from the previous version. So with also help over 80 international trialists, the clinician and the policy make together to redefine the short this 10 domain to 9 domain. Then they provide a 5-point like a continuum. Okay, and also it's validated by different people. To kind of ensure the retest reliability, then also provide detailed guidance. So, in short, this is called a PRESIS 2 wheel. This whole wheel has 9 domains: the eligibility, the recruitment, setting, the organization. So, if you design a trial, you need to thinking about all this area. Okay. So you give a 5-point scale. 1 stands for very explanatory. 2 is a rather explanatory. 3 is kind of balanced between explanatory and pragmatic. So the 5 for very pragmatic. Okay. So since this, this presentation more focused on pragmatic trial. Now let's do some exercise. I like to do some exercise with you. So see how you view this as a pragmatic or explanatory. So for instance, now let's start from each domain. Eligibility criteria. So that's, you need to decide who will be selected to participate in this trial. So general definition for the pragmatic approach is for the eligible criteria is include trial in the trials anyone with the condition of interest who is likely to be the candidate for the intervention if being provided in the usual care for conditions. So as you can see, if, this efficacy is demonstrated, it can apply to the patient in the general setting, right? So I'll give you 2 examples. So you tell me, so you may putting this in the chart of your score. So first inclusion criteria, including all patients age 15 with suspected asthma were included in the study based on the clinical diagnosis of asthma as a standard respiratory testing machinery. Was not available in the rural setting. So basically, it's a crude clinical diagnosis, maybe not necessarily accurate or whatever, but we basically just recruit them into the study. So what do you think? This is going to be pragmatic? In terms of score from 1 to 5, what would you give? Let me see the chart.
Remind us, is 1 is less pragmatic, 5 is more pragmatic, right?
The higher the number, the more pragmatic.
Thank you.
So the one is the one. The 1 is very ERCT. 2 is rather ERCT. 3 is somewhere between ERCT and the PRCT. So the 5 is very PRCT in that particular domain. So I saw yeah, I certainly agree with your assessment. So sometimes it's pretty, sometimes it's clear, sometimes it's not so clear. So let me.
Can I ask a question here?
Sure, yeah, please.
My question is about consent. When something is super pragmatic, do you still need to, not super pragmatic, but then when, in the example where everybody who comes seeks the standard care, now we offer them this, do we still give them a choice of whether they want to enroll in that new intervention or not? And if we do, how does that impact the pragmatic level of it?
I think a consent form, informed consent, is absolutely needed for the ERCT. Okay, so for the PRCT, my personal opinion depends on what kind of treatment we involved. Okay, it could be less than a little bit.
But wouldn't that influence the real life likeness of it?
Of course, we'll influence that. That's what the PRCT, target, right? We're dealing with the real life scenario. It's more complicated. So, whatever people like to do, we shouldn't discriminate them. Something could happen to the patient, so people want to be in there, not want to be. Obviously, still need to be some kind of procedural thing. You need to. You definitely need to get the consent of the patient, right? But
right.
If it's consent form or not, it should be.
Right.
That's
Yeah.
Yeah, I think I might just weigh in on this one a little bit. I think I'd be a little bit less or maybe more equivocal than Ying was. I would say that it can depend. It can depend on if you need the individual level consent form. If you're talking about a pragmatic comparative effectiveness trial where we know that both of the interventions are successful and you're trying to work out which one is going to be better in what context for which types of patients, and you can do it in a way where your randomization is at kind of an individual level, but still through the system, and you're not gathering identifiable individual level data, then typically you would not need to give consent. And so it's really about and I think the stage of science is, you're exactly right. And there's different times and different ways to ask for a waiver of consent. And for a lot of these types of trials, a waiver of consent would be granted. And then a lot of them, it just really depends again on as Ying said, the intervention. And in these cases, typically there's not much risk when you're talking about comparative effectiveness trials. So that's not much into it. But, so I think the more intensive the intervention, the more kind of, feeling like it's a research study, the more out of the usual that it is, then the more likely you're going to get asked to get consent.
Thank you.
Sure.
Thank you.
So the next example, as inclusion criteria, is confirmed the same, for the Alzheimer's. So 16 years of age, so it's very broad, right? Anybody above that age that's, with unilateral facial nerve weakness of no identifiable cause who presented to primary care emergency department could be referred to the collaborating otorhinolaryngologist, in 72 hours after the onset of symptom. So obviously you're going to including the patient. This is excluding the patient with pregnancy, the breastfeeding, the uncontrolled diabetes, herpetic ulcer disease, those kind of things. So that's the inclusion criteria. So for trial like this, how are you going to rate it? It's very pragmatic, or very exploratory, somewhere between. What do you think for that?
Can you remind me again the higher the number, the higher?
The higher the number is more pragmatic.
More pragmatic, okay.
More pragmatic. So 5, 1 is extremely exploratory, 5 is extremely pragmatic. Well, the most number I saw 2, 3. Yes, I agree with you. I mean, it's not. It still has some sense of pragmatic. It's apply to diverse population, right? Anybody above 16 years old, that's gonna apply. So, but it does have, some rigid, inclusion criteria that some people need to be excluded. So, anyway, so that's the eligibility criteria. So I think, you guys got pretty good sense about the pragmatic and the exploratory. So the next one, let's see. I don't know whether I have enough time to do all the exercise. If I just do a couple of this, recruitment it's important, I think, if you're thinking about a pragmatic thing. So the most extreme pragmatic approach to recruit would be do this in the usual care. So where you recruit patients, okay? The only people who attend the clinics with the condition of interest can recruit after they present on their own behave without any over-recruitment effort. Now, give an example, for diabetes control program, investigators search medical record system for eligible participants and then mailing invitation letter. What do you think? It's a very pragmatic, very explanatory. That's recruitment approach. 2, 4, 4, 4. Very is a rather, the 4 indicates the rather pragmatic. Do you think that, how do you think about how pragmatic you can find individual medical record system information? If in the usual clinical care setting, are you able to search for medical record system? I don't have absolute answer. I'm not expert in that area. So, I mean, this is certainly is a hip thing involved, right?
Yeah, I think from my perspective, you know, if you're using the medical record, and there's not a lot of exclusions there, I feel like it's a pretty pragmatic approach. Now, do I think it's going to be completely representative of the population of people that need to work on diabetes control? It's probably not going to be representative outside of the healthcare setting. But it also doesn't, you know, it's not excluding people with hypertension or pre-hypertension or other comorbidities, which makes it feel like they're not looking for the pristine patient that needs to just deal with, you know, their glucose, you know. And so that's where I kind of feel like it's probably more pragmatic, but I think there's more generalizable ways that you could do that recruitment to enhance your external validity.
I tend to be a little bit more conservative in terms of name this as a programmatic. I intend to give like a 3 or something.
Oh, we're only one off.
Yeah, it's not, certainly it's not completely, you know, extremely programmatic, right? It's a, so compared to the next one. So the investigators solicitate people who visit usual care clinics with BMI greater than 25. What do you think? And they try to join the weight loss program. Is it pragmatic or explanatory? That's pretty obvious, isn't it?
Quite funny.
What do you think? It's very pragmatic. Yeah.
I could give that one a 3.
Huh?
Yeah. This is, I mean, maybe other people are tired of hearing me talk about it, but, you know, to me, it almost has the same issue as the one above. If you're saying only people that visit usual clinical care, you know, there's a lot of people that don't visit usual clinical care. And if it's also, you know, solicit people, so if it's a recruitment where you send out flyers and stuff and try and get people in, you're probably not going to get as generalizable a sample as possible. But I agree that the criteria around it is very pragmatic. Hey, we're just looking for people with a BMI over 25.
If you think about the recruitment, I mean, I'm talking about the domain, that particular domain, right? That doesn't involve like a very intense
It's true. It's that.
As long as you do clinical, you know, visiting the BMI, normally people can easily, right, without the privacy of stuff. So the highway stuff you can calculate. Yes, solicit join. From that perspective, from purely recruitment feasibility perspective, I would say, you know, it's very problematic. Anyway, I think because the time, I thought maybe I go too slow today. So these are different and domain setting for the organization. I list all this example. I think I encourage you to do it at home to see how you're going to fill in this number. Okay, so I'm not going to go through one each individual one. So I mean, finally, I like to talk about, because as a statistician, this is the focus I have. Oh, let me talk about that thing. I think that's very important in terms of the outcome. The research primary outcome. Pragmatic approach would be selected an outcome that is obviously important from the patient perspective and also was relevant to the commissioner of care. That people, will decide whether to implement the intervention, based on the results. So let's look at particularly these two. Okay, I'm looking at the second parts. In the intervention, I aim to reduce fall in the elder people living independently in community. Investigators choose two endpoints to study. The number 4 in the elder living independently in the community. The second one is the bone density and the muscle strength. how are you going to give the rating in terms of pragmatic thing? What about the first one?
Early treatment.
What's the first one? First one. What about? I mean, clearly, thank you. So clearly, as a patient, from patient perspective or the patient perspective, right? That's anybody understand the number 4. What the number of 4 means, right? The higher the number, I mean, obviously, it's a very, very relevant to their disease status. So the bone density and the muscle strength is a scientific.
Mm-hmm.
That's highly related to the number 4 that may occur to the elder people, right? That could be using as a surrogate. Sometimes in the randomized trial, we call it surrogate endpoints. Okay, that's to me, it sounds like this is it's a more scientific, it's less pragmatic. Definitely, it's less pragmatic than number 4. Okay, number of 4s, if you look at the definition for the pragmatic thing, it's obviously important from patient perspective and the commission of care thing. So, all right. So analysis, then come to the analysis portion. So pragmatic approach in analysis would typically, it's basically an implement called in the clinical trials called intent to treat analysis. Once you have a randomized trial, so you compare people being randomized to the treatment versus being randomized to the placebo. So it doesn't matter whether these people randomized to the treatment is truly received the treatment or not. The sample may be contaminated. You kind of swap. People may assign to the placebo, they may get the treatment elsewhere, or somehow they do other way around. So this is less likely to happen in ERCT, but it's very commonly happen in PRCT. Okay, for the medicine. So, this approach, primary analysis for pragmatic trial, if you define your trial as pragmatic trial, so this is the primary analysis, intent to treat. Okay. So most ERCT, we're going to use called a by-protocol analysis. You're kind of comparing people that truly receive the treatment versus not. Okay, that's called by-protocol analysis or treated analysis. So that's a different emphasis. That's.
And Ying, would folks call that, would that be similar to like president follow-up analyses? Is that?
Say it again, which one?
For the explanatory approach, would it be more like kind of the present at follow-up, or, I'm trying to think about that, like it's basically for the explanatory approach, you only include those people that actually got the treatment, right?
If you switch, you basically, put people randomized to the treatment. I mean, if they switch to the placebo, you're going to treat them as a placebo. You'll have to do the analysis by protocol.
Yes. Yeah, got it.
So obviously that's the reason why the ERCT, you're going to develop a very rigid protocol. Okay, how you define the treated people on the treatment on the placebo. So the essence of PRECISE-2 that developed the guideline for people thinking about designing the clinical trial, what you need to do. Okay? There's 4 steps. So first of all, you have to be very clear when you do this experiment, what kind of goal you want to achieve. You want to prove the concept, or you want this the outcome of this experiment immediately apply in the usual condition, in the usual care scenario. So that's that's dictating this is going to be eventually is a ERCT or PRCT. Okay, so then, I mean, this is the first thing you need to, determine in beforehand. Then you have to consider, I mean, the design choices. Okay, that's a primary goal determined. Then you try to determine from 9 domains, as we just talked about it. So I talked about a couple of them. So the choices, I mean, the design choices from 9 domains to choose this domain that's relevant to you, to the trial. Then you're gonna score them in each trial or each domain, then to assess whether it's more pragmatic oriented or more exploratory oriented. Then you review the score to see whether it's consistent with the goal you're setting, all right? So then you kind of number of iterations, you're going to review that. Then you basically need to go back to step 2 to modify your design choices if that not consistent with you and the idea you originally developed. Okay, so I'm just highlight these steps. So I mean, if there's a website, this website, you can get a formal training. I cannot use this time to give you all the detail. So I encourage you to surf this website if you're really seriously thinking about your future study in RCT. That's the resources you should use. Okay. Well, now let me just focus on pragmatic trial as RCT. Okay, so what type of from statistical perspective, what we should look into it. So this is a kind of guidance by government in 2019. That's kind of highlight the aspects from statistical perspective when you're thinking about the pragmatic trial RCT. So first of all, I mean, in the randomization, you have to think about it, whether it's going to be a standard it's a patient level. Patient level generally is a standard approach for randomized trial, but sometimes it's not possible. So another thing is at the cluster level, it should randomize the intervention of treatment in the unit level, either clinics, doctor, because patient treat the doctor, one doctor treat a bunch of patients, right? You're not randomize the patient, you randomize the doctor, okay? So, and a community setting, so community sites. So another, it's very pragmatic. This kind of randomization is very pragmatic. So it's basically, as you walk through, it's called a multiple control randomized study. So you basically just determine the cohort of patient for some symptom or whatever. So in a community base, right? So follow them over time. So when you follow them, this is I'm thinking about. It's a very big study, a very big study. So it's a truly a very long-term community-based study. So so you don't when you decide to follow up with this cohort patient, at that time you haven't had a concrete idea, what kind of treatment you're going to be implement on the patient. Has a full picture in the beginning. So basically during this process, once some treatment is available, you select a subgroup of cohort, then you randomize the group of patients within this specific subcohort. Then you compare control, not receiving. You're choosing subgroup who are not selected, then just compare. But you still have a lot of patients, a lot of people available in this cohort, right? So if you have another treatment available, down the road, so you can repeat this process over time. So by doing so, I mean, you kind of have a very pragmatic kind of inclusion criteria set ahead of time, right? That can largely reduce the time for conducting a multiple trial to demonstrate the treatment effect, right? So this is a very, I would say it's very, very problematic. So that's really represent the real world population subgroups. So the blinding, how you do blinding? Sometimes you just cannot do the blinding, right? So it's not absolutely necessary in the pragmatic trial. So if the blinding is not possible, then when you determine the endpoint, you have to think about it. Okay, whether try to avoid using the subjective endpoints. So let's see, only the objective endpoints should be used if blinding is impossible, and for the primary and the key secondary endpoint. Okay, or event or outcome-based event, then the adjudication by the blinded medical experts will be recommended. Okay, you need to use a third party, which is blinded, is adjudicated by the blinded medical expert. I'm talking about events whether you diagnosis, for instance, for some treatment, for some disease, or whether, I mean, the disease is resolved or what. So things should be adjudicated by the blinded medical expert. Okay. Then in the analysis portion, you should blind this. I mean, the analysts, statistical analysts, when doing the analysis. Okay. Another, in the design phase, a design perspective, you know, to avoid the issue caused by the blinding, I mean, a cluster randomization is a reasonable way to do. Okay, so the cluster randomization has a you know, an advantage somehow to minimize the bias caused by the unblindedness. Then another thing to think about in the endpoint, you know, what endpoint, because in the pragmatic trial, so as we sense in the ERCT, basically the data, generally speaking, the data we're getting is quite accurate because through the CRF form, right, case report form, and also validated by the multiple study, at least two, you know, study coordinator. So, but for the pragmatic trial, the data you're getting, I mean, can be pretty messy if you're thinking about the data source. Okay, sometimes we have to use the EHR. That's EHR data can expand, I mean, the accessibility for the endpoints. But as you can see, the EHR can be imprecise. I mean, due to different reasons, right? Sometimes EHR, people put in the information document is a narrative notes, the chart review or things like that. So that can be contaminate the true endpoints. So the endpoint, often in the pragmatic trial, the endpoint information may be missing, okay? Sometimes people using the natural language, you know, NLP to extrapolate the information from the chart review notes, right? So kind of text learning or text mining or some things like that. So, I mean, it's very helpful, useful, and also the inexpensive way to gather this endpoint, but the downside is not 100% accurate, okay? So the consequences, if you not carefully thinking about how to deal with this endpoint, so just using whatever you have from the data system, so that may lead bias in treatment effect assessment. Because the missing data, because the impreciseness of the information, that would definitely lead bias in the analytical results. That need to be taken into account. Endpoint. So also there's a lot of missing data. How you sometimes you can do. I mean, another thing can help is do some kind of data augmentation. So the mobile device now is widely applicable. Sometimes you can think about a strategy, to utilize the mobile device to gather the information and to capture the endpoint that the chart may not contain. Okay, and sometimes you do a little bit of small scale study to the second sampling. Okay, second sampling, double sampling. So I had a very good example for that. So for double sampling, there's a lot of statistical modeling and idea involved. So some fine methodology need to be developed. I can give you a simple example that I experienced. So we actually conduct a community-based HIV trial in Africa. So we try to put HIV patient in ART, treatment. So we start to follow them. So often, because a lot of people coming from the small village, remote village, sometimes the vital status we don't really know. Okay, so in the end, we saw people not coming back for the treatment. Then the system just coded them as a disengage, right? To say everything, suppose you coming back every 3 months, stuff like that. So if we didn't see you for like 6 months or so, we just say, okay, this person is lost interest to be treated. Then we just code it in the system as disengage. So we try to, the goal of this study is try to improve the engagement of the treatment for Africa people. So clearly that can be problematic because disengage, coded as disengage, is not necessarily truly disengage, right? You're thinking about Africa, people in the remote village, that people may be just dead. You're just not able to ascertain their vital status. So that's information, death information is missing for some people. If you just treat it as a disengage, this information is truly disengaged, definitely there's a lot of bias, can be introduced. So we actually spend quite a bit of effort to developing some new methodology, try to do this. We can do a small sample, go out to randomly get some people from the village, then to ascertain their true vital status. From that information, then we truly find that some people classified as disengaged actually dead. Okay, those information can help us to developing some kind of methodology to apply to the whole population. So develop a new procedure to estimate the disengage rate and also the mortality rate as a consequence of disengage. This methodology is actually right now it's applied the WHO for broadly to estimating the mortality of HIV mortality and the engagement. For that approach, definitely it's a lot of fine methods need to be implemented. So, and also some kind of, if you're getting some endpoint is imprecise, something like that. So, some portion is precise, some portion is imprecise. Sometimes you have to use now modern machine learning method to predict outcome. To predict outcome, try to have the fair estimate of the outcome if given that outcome is not precise. Okay, so using data from partially labeled data to do this exercise. So that kind of thing, as you can tell, in the pragmatic trial, sometimes statistical analysis is a lot more involved. I mean, it's a lot more complicated than the ERCT, simply just two sample comparison or things like that. So this is a lot more involved. So, I mean, number one, you're going to use the causal inference tool. So this is not an ideal, some kind of randomized trial. So missing data, then the imprecise data collection, and also blindness, this kind of thing. So if you still want to do the causal, draw the causal inference, you need to use more advanced methodology, sometimes like propensity score adjustment, the marginal structure modeling, and the double robustness method. Those kind of generally fancy statistical tools need to be implemented. And also when you have, as I already mentioned, you need to use kind of various algorithms, like machine learning algorithm, okay, to try to predict the endpoints, right? Then if you predict the endpoints, this endpoint is not precisely collected, it's based on the model. So anything based on the model is subject to the measurement error. It's not, right? It's a model derived error, as same as a kind of measurement error. So the measurement error mechanism need to be built into the analysis plan in order to correct the potential bias. So in one word, it needs, if you really want to do things right when you're facing this kind of issue, I mean, more sophisticated statistical methods is imperative. Okay, I think I only have 20 minutes left. A terrible story, I'm going very slow. So I don't have the time go through that. I think I'm hoping you can read my notes about that case study that's challenging about the community-based pragmatic trial that's happened in England. So I can tell you a little bit about the story. So they have this is a big study. Okay, they try to, developing some kind of intervention. I mean, it's a behavioral. I believe it's a lot to do with the behavioral dietary, intervention. One is 12 months very aggressive intervention. One is a normal intervention. Try to reduce the obesity. So I mean, the people they try to recruit is the obese adults population who already achieved like a 5% weight loss. So that's the population you try to target. Okay, so they have the plan, the 2 years plan to recruit patients, but somehow, I mean, the study was closed in September 2012, and have to convert to the feasibility trial. They're facing enormous challenge. I mean, for different reasons, bureaucracy, and also the concept about the recruitment, stuff like that. So I don't think I have enough time to go through that. Let me just talk about the trial I've been working with. So I want to focus a little bit more about the cluster randomization because this is a typical PRCT. Okay, I show you two examples. So cluster randomization, this is a common pragmatic trial design in community setting when the individual randomization is not possible. Think about it, for various reasons. So mainly due to the reason that intervention can only be administered on the facility-wide or the community-wide scale, and the individual. I mean, now the analysis can be tricky because the individual within the cluster are correlated. So the intra-cluster correlation need to be incorporated into power calculation and the data analysis. So when you design this trial, you have to take in that intra-correlation to consideration. It's not like individual clinical trial, you're assuming each individual are independent, right? It's not independent in the cluster. So typically, you have three different types of cluster randomization. One is a parallel cluster randomization. One is a parallel cluster randomization with a control phase before randomization. One is a step-which design. So cluster start with control, then gradually roll into intervention. So graphically, parallel CRT just like this. You have to only one step, okay? So, but one step doesn't mean they have to be done at the same time. It could be done at a different time, but they just involve either in the control sites or the intervention site. So CRT-BA with baseline control is being start with everybody is in control. Then in the second step, some of the cluster randomized into intervention, some remain in control. Okay. Then step which, as you can see in the beginning, everybody, it's kind of combination between these two, right? Everybody is in control. Then some of the cluster randomized into intervention. Then rest remain in control. Then moving up. So eventually, all the cluster will be not randomized, will be enrolled into intervention. So for this step which CRT, you have 5 steps, 1, 2, 3, 4, 5. Okay. So, I mean, simplest CRT is a parallel CRT. Okay, it's a very natural design for measuring the community effects. Obviously, it's going to be less efficient than the individual-based RCT because the intro cluster correlation. You can do the individual, definitely the individual randomization will be more efficient, which means you only need a less patient involved than the cluster randomization should achieve the same power to detect the effect. So CRT-BA allow the measure changing from baseline. So, I mean, the upshot of this design is just remove the potential, confounding effects in assessing the intervention because everybody starts from the control. So we're looking at the changing within cluster, right? Changing in, cluster. So this is often sometimes called the unidirectional crossover trial. Crossover trial, which means you have 2 treatments. So somebody start with treatment A, then switch to treatment B. Then somebody start with treatment B, switch to treatment A. So try to reduce the bias from the ordering of the treatment because the residual effect of the intervention. So
I asked 2 questions there. Number one, is it possible to do minus year 1 as your baseline data? So if, let's say your outcome metrics are hospitalization and emergency room use. So could you recruit the patients at baseline and get those data for year -1? In other words, last year, how often was a patient in the hospital and how often were they in the ER? And then initiate the intervention and look at those change in behavior in a year.
Sure, yeah. This is a typical like a CRTB.
Yeah, only year 1 is year -1.
Yeah, it's okay. I mean,
okay. But and then the only reason it's unethical in this diagram is because sites 4, 5, and 6 are denied access to the intervention.
Yeah. I mean, I would say, maybe this year is a confusing. You may say step. Step.
Oh, okay.
So year -1 is a step 1. Okay. So this is a unidirectional crossover trial. This is a half crossover. It's not complete crossover. Okay. So step which clinical, cluster randomized trial remove, basically, I mean, if you use crossover trials, it's involved a non-ethical issue, right? So you basically don't let the half of the patient not using the intervention, right? So maybe in some scenario, it's involved non-ethical issue. So for that reason, I mean, the step which design, which is, it's more involved, but somehow can address this kind of non-ethical issue, because in the end, everyone is going to be rolled into the intervention. Okay, it's still able to allow you to compare with the baseline, which remove the confounding effect, but also remove the non-ethical issue. But it takes a little bit longer to run. Okay. So the design aspect, so the sample size, how you calculate the sample size, basically is that this is the total sample size required. I mean, NI basically is the sample size based on individual ERCT. So if you want to demonstrate the effect size with certain power, you can calculate the total sample size based on the individual level. So multiply by this kind of design effect. Okay, that's going to be the total sample size for the cluster randomization. So the design fact, you have parallel CRT, CRT-BA, CRT, CRT SW, step which CRT, you have complicated, the more complicated it gets, the more complicated design effect. I mean, design factor leads to, okay? So that's how you calculate the sample size. So sometimes for the step which CRT, either you need to determine how many, if you know the cluster size beforehand, and also number of steps you want to conduct, that's depend on the limitation of the study period, right? If you want to fix this in 5 years, in 4 years, you already know how many steps you have, right? So you just want to know how many cluster, the number of clusters you needed. So this is the formula. So if you, sometimes you only have this many units or hospital involved. So the number of clusters is fixed. So and the number of steps, because this is determined by how many years the study, total study time. Then you want to determine how many subjects need to be involved in each unit, in each, that's the cluster size in each step. That's a little bit more involved because the formula involve n, which is unknown for the design factor. So there's an algorithm assessed to determine sample size n. Okay. Anyway, so this is a general statistical property for the step which CRT, which I left you to look at it. So let me give you a case study. So this is the study. Well, unfortunately, we submitted. We just received the review last week. The score is 18%. It's not good enough to be funded, but that is the study we designed, for the cluster randomized trial. So basically, the goal of this study is to test the efficacy of Make Play Safe, MPS. This is an innovative, theory-driven, and two components intervention aimed to improve concussion recognition and the reporting among the boys, the youth soccer player, okay, in the 9 to 12. The intervention is we use the virtual reality technology in conjunction with the strategy that promote the parent-coach communication about the concussion. So the purpose is we wanted these kids to be aware. If they have fall, they have collab with other player. Sometimes it's a concussion. They want to, they want to make them aware of that, to report, to prevent. The further injury. So that's the purposes. So we're developing this kind of virtual reality things, putting the app. So it's kind of record the patient, the parents to communicate with the kids, kind of training the coach and the parent how to communicate with kids about this, stuff like that. And also, so the youth athletes. So this is the 3 aims. The first aim, well, is determine the efficacy of the intervention on soccer athletes' concussion symptom recognition and the reporting intention. Second one is to determine the efficacy of intervention on soccer athletes' concussion report. So let me ask you one more question. So among these 3 aims, right? If you want to rate as a pragmatic or explanatory, what do you think? For the aim 1, it's very pragmatic or explanatory. Anybody has any? 1 minute. Second one, it's concussion reporting. So actually, the main goal is try to enhance the rate of concussion reporting, right? So the number of concussion reporting, I would say that's, most important to the parent, to the child, right? So this endpoint is more pragmatic than the knowledge, right? And the symptom recognition and the reporting intention and also the communication score between the parent, effective communication between the parent and the child. So if purely we propose this study doesn't say anything about the pragmatic or the explanatory. That's just the RCT, class randomized trial. But now, put in this context, this is, to me, it's more pragmatic than the other 2. Okay. So this is 2-arm class randomized trial to test the efficacy of MPS with 2 component intervention. So one is with virtual reality app. Second is a message notification program for parents and coach try to enhance their communication. So the study participant is 9 to 12, the age between 9 to 12 youth soccer player. So the recruitment, we kind of randomize in the league. This is happening in Ohio, Central Ohio. So have a many soccer league. So we basically, athletes will recruit from the 8 youth soccer league. Okay, so each league, we're gonna randomize 8 teams by age, randomized block by sex, because the boy and the girl, and also the age. So each combination have 2 teams, all right? But the randomized is conduct at the league level. Okay, so this is class randomization. So the control athletes only receive the concussion education materials pamphlet. It's nothing, not very much intervene from the parent, from the virtual reality. So we decide to do the parallel RCT. So this is the basically schedule. So this is a pre-season survey. We collected the baseline data. Then we start to intervention, and then during the season, the play season, we kind of collecting the second outcome, which is the pragmatic endpoints, right? It's the concussion reporting. They get training during the baseline, watching the videos, stuff like that. Obviously the communication between parents is ongoing, between the parents coaching with kids is ongoing. Then after the season, right after the season, we kind of do the examination again to see how much knowledge about the concussion and awareness still remain, okay? Then it's a sustainability test 6 months after the season end. Okay? That's the study design. So the power analysis. So here we determine the step size. We determine the sample size first. That's the how many team we can do the study. So based on the capacity of our research team and based on the funding level, okay, that's that many subjects, so many teams we can do in 3 years. Okay, so it's not like we calculate the sample size. We determine, we assess the power. Do we have enough power to convince the founder that we can do this? Okay, so we did the pilot study. This is from the local, I think, and the PI getting the grant from the institution to small scale study to find out the intervention increased the change in the score by 7.1%. And that standard deviation then give you the standard effect size is 0.85. That's pretty moderate. Then we based on what we have, the sample size, and we're assuming we don't know what the intercorrelation coefficient. So I kind of calculate from very low to very high. So obviously more than 0.9 is almost impossible. So the smaller the correlation, I mean, the more efficient of the study. So anyway, so we all know each team we assume is made by 12 athletes. So the attrition, assuming not everybody will reporting, right? Attrition is 20%. We're assuming at least like 12 athletes will report the score, will participate in studies. In the end, we find out the study is actually powered at 0.94 to establish intervention efficacy. So based on the parallel ICT. So I think I better stop here, even though I have a second example is about HIV study that's in the East Africa based on the stepwise design, but since I'm running out of time, so I just let you to read this slides. If you have any question or you have this need, feel free to reach out to me. So for the future design or study, you thinking about contact. All right.